So this video is actually really important. Although the case of Carol isn't actually named on your spec, it does say that you have to understand how case studies are used in clinical psychology, and you also need to have an example of that. So I've chosen to look into the case of Carol because you can also then use this study to support the use of CBT in a treatment for schizophrenia. So it's kind of dually effective for you. Now, just a quick reminder that case studies are an in-depth, detailed study of either an individual or a small group. They may use lots of different research methods within them, so interviews, observations, case histories, and triangulation is used where you pool all data from different research methods together and you look for trends and themes within that. Now, they're really useful, particularly in clinical psychology, because they allow us to study a particular phenomenon in a way that may not be studied any other way. So, for example, when you're trying to find out about a patient, one of the best ways to do it is a case study, because you get to understand their family history, their life, their occupation, the environment that they live in, and therefore make decisions about how that correlates to their symptoms or to the disorder that they're experiencing. Now, case studies, because of this, allow us to produce really valid data where we get all of the information in a natural setting. However, because case studies are done on a really small group of people or an individual, they're not necessarily generalizable to everybody else, and they also lack reliability because the situation that you're looking at is unique because it fits that individual. So if a researcher at another moment in time or with a different patient tried to do it, they would find different results. Therefore, we say that they lack reliability. Now, the case of Carol was carried out by William Bradshaw, who investigated a young female patient who had schizophrenia, and we call her Carol. That's not her real name. Obviously, ethically, we have to produce and respect confidentiality. But it's a key piece of research because it shows the role that CBT has in treating schizophrenia, whereas actually before this case study, it was regarded as inappropriate or an inappropriate treatment for schizophrenia. So Carol is a 26-year-old white female patient from America. She's just started her first year at university. She was from an upper middle class family and was the third of 5 children. There was no history of psychiatric illness in the family. But during her first year at college, Carol started to experience auditory hallucinations and delusions, and she withdrew from people and started to act in a bizarre manner. Carol was hospitalized many times and was diagnosed with undifferentiated schizophrenia. Carol was assessed on a global assessment of functioning, which is a GAF scale, which rates how severely the schizophrenia affects her everyday life. Now, she was assessed as 30 out of 100, but 30 is a really low score on the GAF scale. It means that Carol really wasn't in a good place. Carol was diagnosed using the DSM-4, and she was taking thorazine as an antipsychotic drug. She moved back to live with her parents from university because she couldn't work or function independently, and she became completely withdrawn. Her psychiatrist referred her to psychotherapy to help her cope with community living and manage the illness, and therefore Carol began a course of CBT. So the aim of the case study was to investigate how CBT can be used with a woman with schizophrenia. This is a study of an attempt to use psychotherapy to treat schizophrenia where drug treatment had previously been preferred. There had been little evaluation of the use of CBT for schizophrenia. Now, psychosocial functioning, which is general mental health, was measured by a role functioning scale. This is a checklist which gives a score for work, social, family relationships, and independent living, and then totals it all together. The goal attainment score, or the GAS, measured how many of the goals she agreed with her therapist that Carol was meeting. These might be things like cutting down on medication, coping with hallucinations, getting a job, etc. Hospitalizations were measured by the number of times Carol was admitted back to hospital, and the progress of symptoms was measured using the Global Pathology Index, which is an 8-point scale ranking how severe the symptoms of schizophrenia are. Carol's baseline score of 7 indicated severe problems, such as inappropriate mood, hallucinations, delusions, impaired judgment, disorganized thinking, and an inability to care for herself. Now, this is a prospective case study because it tracks Carol's progress over 3 years of CBT and then follows up with her 6 months after the therapy and then a year after the therapy again. Carol followed a standard treatment of CBT. The first step was developing a rapport with the practitioner, so she developed a relationship, and to do this they regularly went for walks together, and the therapist actually disclosed information about themselves. In stage 2, it was really important that Carol understood CBT and decided on the treatment goals and what she wanted out of the process. Now, this meant educating Carol about schizophrenia and about different ways in which it might be treated. Schizophrenia can involve a vulnerability to stress, so Carol's focus was improving the way that she copes with stress. Stage 3 was the treatment itself. A weekly activity schedule helped her to cope with the loss of daily structure after leaving hospital. She was asked to record what she did during the day so that she and the therapist could review her daily life, recognise the signs of stress, and therefore come up with different coping strategies from this. The middle phase involved a 16-month of building more strategies to cope with stressful social situations. The focus was also on Carol's fear that she would suffer a relapse and go back to hospital. Finally, there was an end phase which lasted about 3 months. Carol developed plans to maintain the treatment with the therapist, and for example, Carol wrote cue cards with coping strategies summed up, and she would review these every day. The results showed an improvement in psychosocial functioning, achievement of goals, reduction in symptoms, and a reduction in the number of hospitalizations. In fact, Carol was never rehospitalized. Carol experienced improvement in functioning in all 4 of her measures after a 3-year course of CBT, so that allows Bradshaw to conclude that CBT can be successful in treating schizophrenia. Bradshaw and Roseberg in 2004 carried out a meta-analysis of the case studies of 22 patients and suggested that 86% improved their psychosocial functioning and 82% had reduced severity of symptoms. These findings support the claim that CBT is effective with regard to schizophrenia. You must remember through all of this, though, that CBT was not being used alone with Carol. Carol and the other clients were also taking antipsychotic medication. So this is probably argument for an integrated treatment and supporting the use of CBT alongside a drug therapy. Now, evaluation. We've already mentioned how case studies are difficult to generalise, but specifically to Carol, she is female, and partly because Carol's type of schizophrenia, which was undifferentiated, is not the only type of schizophrenia. So this suggests that CBT may not be effective with other types of schizophrenia and therefore makes it difficult to generalise. Carol is also quite an individual sufferer here. She's female, whereas it's normally male. She has no family history of mental disorders. She's young, with a very supportive middle-class family. Bradshaw and Roseberg did assess the utility of CBT of schizophrenia and did find it effective 80% of the time. The reliability. The rapport that Carol was able to attain with her clinical psychologist was very difficult to replicate because sometimes it's bad and unique to every single case. However, what was highly reliable was the standard CBT procedure that was followed with the case of Carol. By using measures such as the GAS, the GPI and the RFS, they're all well-established tools that are already being used by psychiatrists. Carol's symptoms were checked against the DSM-4, and the same measures were used at the start of the study, 3 times during the therapy and twice afterwards, which actually ensures test-retest reliability. The application of this is that it promotes the use of CBT to help treat patients with schizophrenia. The advantage of CBT is that clients can lower their dependency on antipsychotic drugs and therefore reduce the side effects that the drugs give and even give up on drugs altogether. However, because it's very costly and time-consuming, the treatment is currently only available to about 10% of sufferers in the UK. The case study delivers both quantitative and qualitative data about Carol, which is really helpful when getting a valid judgment. And because it took place over 4 years, we can be sure that we are seeing real changes in Carol and not just behaviour put on for the benefit of the researcher in demand characteristics. Ethically, Bradshaw did respect the young woman's dignity and concealed her name using the pseudonym Carol. Carol was in too far bad a state, though, to consent to the study and to consent to sharing details of her progress with the researcher. Therefore, presumptive consent was obtained. However, at the end of the study, Carol was much healthier and was in a position to give informed consent and did consent for all of her data to be used.